So welcome back to Paul. Paul Corris from Newcastle. Are we saying you recently? You know, professors never retired, do they?
Apparently not.
No, they certainly don't. But you're more than welcome here, Paul. And it's been a good relationship between yourselves and ourselves. And transplantation is something that we see in the PHA is something that will be becoming more and more part of our story as well over the next few years for many a reason. But some of it Paul will explain there, and then we've got a couple of exciting announcements towards the end of this presentation as well about transplant per se. So over to you, Paul.
Thank you, Ian. And it's never difficult to accept an invitation to come and speak at this conference, and I usually learn something here every time I come. But I have to say this has been quite exceptional because I met Betsy Corris, who's 3 and a patient with PH, and we share, on my side, a common great-great-great-great-grandfather. So I've met a part of the family I never knew existed. So that's amazing. So the first question, which we saw, suggested that about 1 in 5 would not want to go down the line of transplantation, even if it was suggested that that is what would be advised by the medical team. And what I'd quite like to do today is to perhaps give you a true light on what transplantation can offer, and maybe just make those of you who feel, it's not for me, perhaps think again. And I think probably it's better to think about this talk on all you need to know about transplants, but we're afraid to ask, because it is scary. The reason that 20% of you felt, maybe not for me, is it seems very frightening. But don't worry. The first important point is, fortunately in the UK, organ transplants are best left to the profs, and there are plenty, or the professionals, I should say, and there's plenty of us around, so don't worry. Bit of history, because everybody knows and can remember when the first heart transplant was done, but very few people will actually remember when the first lung transplant was done. It was done before the heart transplant, and it was performed in 1963, and the patient only lived for about 18 hours, I think. So it wasn't long, but there are a couple of important issues, and one of them is the donor was a non-heart beating donor, and I'll come back to that in due course to show the relevance of it. But this was Jackson Hardy, who died last year in Mississippi, who undertook this transplant. And then about the next 40 that were undertaken all failed, largely because where the lungs are joined to the windpipe in the recipient, that join never, the plumbing wasn't good, and it always broke down. So that was inevitably leading to death. But once that problem had been sorted, transplant started. And you can see here on this graph, so here we have the number of transplants. Activity worldwide began very slowly between 1985. I came onto the scene and was involved in the first lung transplant in Newcastle in 1987. So in terms of lung transplantation, I'm quite an old man. Some people would say I'm quite an old man anyway. But anyway, and you can see the steady rise, so that in 2016, there were just over 4,500 transplants carried out. And as you can see, these are only isolated lung transplants. The first successful heart-lung transplant was carried out a few years earlier than this. And although heart-lung transplants are carried out, there are very, very few carried out worldwide now. It's very rare to have a heart-lung transplant. So I'm going to predominantly talk about lung transplantation alone, because for the majority of patients with pulmonary hypertension, that's all you need. And that's another, if you like, second important point. It's an amazing thing. Many of you will know that there's a lot of work goes into working out how your heart is coping with the problem in the blood vessels coming out of the heart that gives you pulmonary hypertension. And the amazing thing is, if you plumb in a normal lung circulation, so there's no resistance, or the resistance to blood flow from the heart through the lungs is back to normal, the heart invariably recovers 99.999999%. So in the early days when we thought the heart wouldn't recover, and you had to transplant the heart and the lungs, was completely wrong. We've learned fairly early on, actually, that all you need to do to get things back to normal and to get the heart virtually back to normal is to get the resistance to blood flow through the lungs back to normal. But you need two lungs, and in many of the transplants, you can see that although there are single lung transplants carried out, compared to the double lung transplants in purple, and certainly from a pulmonary hypertension viewpoint, everybody now does double lungs rather than single lungs, and you can see here for the idiopathic pulmonary hypertension over the years, very, very few single lung transplants, really anecdotal, only if there's something special or specific about that individual. Everybody has a double lung. And the reason is principally because, so here we have survival. So the higher line means better survival. Bilateral lung, you can see survival is significantly better than for single lung. So it makes sense. But of course, just to throw this into the thought box at this point, if you've got a donor, and we know there aren't enough donors around at the moment, if you're using two lungs rather than one lung, that means there are less people that are going to be treated. If you are requiring a kidney and there are two kidneys, well, nobody ever transplants two kidneys into one person. There are always two recipients if both kidneys are functioning well. But for the lung, and certainly for pulmonary hypertension, we need two lungs. Okay, and if you look now again, so here's survival, just concentrate on this blue line because there's an important message here. So if you drop rapidly like this, that's not so good. That means a lot of people are dying immediately after their transplant. And these are the patients with idiopathic pulmonary hypertension. But thereon after, patients seem to do quite well. They never quite catch up to the patients with cystic fibrosis. But they do spectacularly well in terms of outcome. But if we now forget what happens in the first 3 months and say, okay, let's just see if you survive to 3 months, what happens? You can see we're very close to the cystic fibrosis line. So pulmonary hypertension the results are significantly better than some of the other indications for transplantation, such as COPD or pulmonary fibrosis. And this slide actually hides a very important issue because we've become very much better in the last 5 or 6 years in techniques, and I'll come on to this, for keeping people alive better with pulmonary hypertension immediately after their transplant. So this reflects history going back to the 1990s. But actually, the outcomes will be much, much better now for first time. So this drop that takes place historically for patients with pulmonary hypertension has virtually been eliminated. And so we're starting off right up here now and would be much closer to that purple line. So that's an important point to get through. And then I'll just throw in, those are all pooled figures. This is a slide, it's a little old now, but it's when we had done 1,069 transplants, just to show the improvement over the years from Newcastle, and to show you that around 50% of patients will be around 10 years. So we're not talking about 1 year, 2 year survival now. 50%, the average survival of all comers is 10 years. And we have plenty of patients surviving 20 years now. Indeed, only last week, I met the mother, the ward sister from the outpatient, transplant outpatients, sent me an email saying, X was here. She lives on the Isle of Man, and actually Corris is a Manx name, so that resounded with me. Saying, X has just made 20 years. And she said, I can remember when I was in the clinic and she came to see me 10 years out after a transplant. I said, right, now the challenge is to get you through the next 10 years, and I want to be seeing you in 20 years. So 20-year survival is certainly not unknown. Around about 20% of our patients, when we look back, make 20 years after transplant. So the idea that transplants invariably don't last very long is not right. It's true to say that only 50% will make 10 years and only 20% at the moment are making 20 years. So we've got room for improvement. But, medicine improves year on year. You've only got to think back to the very first PHA conference. What's happened in PH? Well, the same things are happening in transplantation, as I'll show you. But of course, the excellent work PHA do in terms of finding out what patients really, really want, a bit like Spice Girls, is told us that it's not just living how long you live, but what sort of life you're living. And everybody prioritizes living better and having the ability to do more. And so this slide, basically, it's quite a complex slide. But if you'll understand functional class, because you get asked about that every time you turn up for clinic. 80% of our patients at 5 years after transplant, after transplantation, will be at least in functional class 2 or 1 in terms of activity. So it conveys an excellent quality of life as well as extending your life. And so meets, I think, many of the important things that you want out of drug treatment and all the other treatments you have for pulmonary hypertension. Transplantation will fulfill those things that you want. Okay, so I touched upon at the beginning one of the issues about transplants, and that is there are far more patients out there who need one than are getting one. And there are World Cup. We got World Cup rugby coming up this summer. There are league tables for who's doing well and who's not doing so well. And I don't reckon we're doing terribly well in terms of worldwide lung transplant rates. This was 2013, but nothing much has happened since then. So we're sitting just below Luxembourg. We're above Italy, but if you think Belgium is up here, Australia up here, even Ireland is up here. We're not really cutting the mustard here. So there's a lot of work to be done. And the reason there's a lot of work to be done is if you translate that through. So here we have the number of patients 250 patients listed for transplant and what happens to them over the next 3 years. Only 70% of those patients will have been transplanted. 5 will still be alive waiting. 4 will have got too sick to be transplanted and some will have come off the list. And 23 will have died. Well, that's a tragedy. We have to cut down, not 23%, will have died. And so clearly what we need to do is to significantly increase that 69%. And decrease that 23 and that 4%, so there are less deaths on the waiting list. And there are a couple of ways in which we can do that. So I'm not smart enough to give you the questions beforehand so that we could make this into a response, but you can share a show of hands. Most of you, I hope, will be aware that Max and Kira's law came in. It was agreed in Parliament and it will be brought in next year. And this states that everybody who dies is regarded as opting in, that their organs can be used for transplant. And that if you don't want your organs, you have to actively opt out. And that's obviously complete reversal of where we are at the moment. So how many of you think that this will massively increase the number of organs that we have and massively increase the number of transplants? Show of hands for those who think it will, and a show of hands who think it won't. Yeah, well, actually the audience is well educated, because sadly it ain't going to increase the numbers as much as the politicians and even NHSBT say it might. And one of those reasons is relatives will still have to give permission to use organs despite Max and Kira's law. How many people agree with that? And how many people think we can just use the organs without the relatives? Okay, well, you're not doing quite so well on that, because relatives will still have to give. Although it won't be law, there's a verbal agreement from all the transplant centres and the people who are involved in the governance of organ that we will still need to ask relatives, and virtually no transplant centre will be seen dragging organs out of the body of a deceased relative with the other relatives banging on the door of the operating theatre, like you see on Holby City, saying, "Don't take those organs out." That's not going to happen. So I won't go through this question. Still, the most important information to give whenever you can is very important for the public at large to discuss as a family unit their wishes and make sure that the family and the next loved ones know exactly what your wishes are in terms of organ transplantation and or at least organ donation, I should say. And the second thing is, just because there are more donors doesn't mean to say we can use the organs. Unfortunately, many of the organs get damaged during the dying process, and therefore we can't use them safely, even though the dead deceased donor would like to give the organs. But there's another side to this, and if we look at what was happening in 2001, let's look at Australia and the UK. The number of lung donors compared to the donor availability, where there was more than one organ used, around just under 40% were being used, whereas in the UK, a little over 15%. And we've actually got worse in 2005. So we're only using 15% of multi-organ donor donated lungs compared to nearly 50% in Australia. And that's an issue, it's a very complex issue, but there's clearly a lot of work to be done to persuade the transplant units and the transplanting surgeons to take risks, acceptable risks, because this is a more risky percentage compared to here. But on the other hand, if we want to maximize the benefit of transplantation to the maximum number of people, we need to recognize that some acceptable risks have to be taken. So what about this question? Only organs from donors who meet brain death criteria can be used. Yes? Show of hands for those who think you have to be brain dead to be a donor. Okay. And those who feel no, presumably the other group. Well, the no's have it, as Mr. Burker would probably say. Because yes, although traditionally brain dead donor with brain death, there are also, remember, living related or non-related. Actually, there's not much lung activity, but there's a lot of liver and kidney living related. But now we can also use organs from patients with so-called circulatory death. So they won't pass the brain death criteria, but they are judged by non-transplanting people. In other words, the intensive care consultants, that the only reason they're alive is because of the circulatory support that they're getting, which can't be managed long-term, and that any meaningful life would be impossible without continued ventilation and circulatory support. And in fact, if we actually look now at the number of donors, just look at the light blue. It's the DCD donation, the circulatory death, that has increased quite dramatically compared to brain dead classic, which has gone up a little bit of late. But the rapid rise in donation is principally due to those patients who are not strictly brain dead but have a circulatory death. So I thought I'd touch upon a couple of important new growth areas. Just as I said at the beginning, as in PH, over the last decade, there's been a huge development, in fact 2 decades for the PHA. So there has been in transplantation. And there's a super acute waiting list for patients now, and that's particularly relevant for patients with pulmonary hypertension. If you're not doing very well but a very good transplant candidate, there's bridging to pulmonary hypertension, bridging to transplant. In other words, maintaining life with extracorporeal support. In other words, circulatory support and ventilatory support in some instances, not many now, for PH. EVLP, and I've had to add this slide because up until 6 months ago, I still was a skeptic about xenotransplantation, but there's work. So xenotransplantation is using modified animal species, principally pigs' organs for human. There have been major developments, I would say, in the last 18 months, so that I'm no longer sure that xenotransplantation won't be a reality. And I would suspect I'll still be alive now when the first human xenotransplant is done. I'm not going to say any more about that at this point. So just to fill you in on a bit of information, these are the lung transplant centers that you may be referred to for your transplant. And at the moment, the organs that are used in these centers primarily go to the zone around where these centers are. So the country's split up into zones. And so there's a zonal organ allocation. But if you are a very sick patient with PH, for example, and there are certain criteria of sickness, so you've got to be pretty damn sick, it has to be said, you get onto the national organ wait list, and therefore the first organ from any of these zonal allocations will automatically go to you, irrespective of which center you're in. And that's very sensible, and it's been shown in other countries to be a highly effective way of reducing deaths on the waiting list. The second thing about how can we get away with this problem of a lot of donor lungs not being used for transplantation. And this is another huge area of development, because what we now do or can do with organs that are suitable or not suitable for transplantation is to fix them. And so what we do is we take the organ from the donor, we bring them back home in the traditional way, and then we put them in a box and we hook up the lungs to a pump and pump blood or other fluids through them, and we ventilate them. And then we can treat them with antibiotics if they're infected, or diuretics if they've got water in them. And in case you think this is pure fantasy, there they are. So this was taken a few years ago now. And these lungs were transplanted, in fact, into a young man with cystic fibrosis. And they wouldn't have been suitable for transplantation when they first came back, but we cleaned them up and then we used them to successfully save the life of a young 26-year-old cystic fibrosis boy. And the technology has come on a lot. So we can do a whole range of drug treatments, different ways of perfusing the lung, different inhaled agents, and even gene or cell therapy. And this will all be real. It's happening now. Fairly simple approaches at this point but over the next 5 or 10 years. And this will all mean that we can increase that percentage number of lungs that are used when they're offered from 15% up to maybe 50%, maybe 60%, who knows? That can only be good. And the technology has moved on, and one of the thoughts might be that instead of all the organs going to individual transplant centers and then transplanted into the recipient from that center, why don't all the organs go to an organ repair center in Birmingham or even Newcastle, who knows, or Cambridge, and get, whether it be lungs or heart or kidneys or liver, they all get repaired in the organ repair center. And there's lots of technology now, lots of smart machines. That old box is gone, and industry has come in so that the technology is very good. And so the teams go out and procure the lungs. They come to an organ repair center, and then those cleaned up organs are sent to the Newcastle, the UK centres, and then maybe what about, I didn't actually put London on here, I do apologise. I said it, Airfield, sorry. But you know, we, never mind Brexit, in the medical world we still want to work with our European colleagues, and there's no reason why organs couldn't, if they were non-suitable in the UK, go to Paris or Hanover. And so the organ repair centre model is, I think, something we're going to be seeing, probably nationally run, less likely to be internationally run. So I touched upon how can we bridge patients to transplantation. So these are from colleagues in Hanover, and patients all gave their written consent to show their photos. So these are all patients waiting for lung transplantation without the pipes supporting their circulation, and they're attached to a machine called ECMO, and I'll come on to that in a second. But the amazing thing is these patients can still eat, talk, take part in physio, so they can be successfully bridged. If you pulled out these pipes, these patients would all die. They're kept alive with this machine, but they're capable of chatting, talking, reading, and doing exercise. And the reason is that this was the face of ECMO 20 years ago, huge, lots of bulky equipment, whereas now we're down to a pump and a filter, a bit like this, and it can be mobile and attached to a wheelchair or what have you. Okay, so we thought I'd speak for about 30 minutes and then open it up, because there may be things I haven't covered that you'd like me to cover, but I will leave you with a couple of, I think, important take-home points. And this is addressed particularly to the 20% of you who are a bit scared maybe of thinking about transplantation. If your health-related quality of life is poor and your risk score, which probably many of you now know about, because we now can, with fairly simple measurements in outpatients, work out whether you're at high risk of something bad happening. If, despite optimal medical therapy, you also, this is a two-way business. Let's ask about transplantation. You don't necessarily have to wait to be told about it. And I would encourage all of you, and particularly those of you who are interested in it, to ask early. But I ask you to do something else. It's your right to come and chat to a transplant centre. That doesn't mean to say that the PH centres don't know anything about transplantation. They do. They know lots and lots about transplantation. But the reality is transplant centres know more about transplantation. And before you make your mind up, I would always ask if you could take a trip to whichever transplant centre your PH centre uses, to speak directly to the transplant centre. All of the transplant centres are busy, but all of the transplant centres run outpatient clinics pre-transplant to discuss these sorts of issues. Just as you would rather go to a PH centre, even though it might be 200 miles away, than your local district general hospital for advice over your pH. Go to your transplant centre for advice regarding A, your candidacy, and B, the most up-to-date information about the realities of transplantation for you at that point. And I'll leave you with something that's been occupying my time in the last 2 or 3 years. Newcastle Gateshead was successful in making a bid to host the World Transplant Games. I happen to be medical director of these, and they're taking place in August the 17th to August the 24th this year. And we'd be delighted to see if some of you are interested to come up and see what the sort of life is and what athletes and non-athletes can undertake. Newcastle Gateshead is going to be Transplant City that week. Lots of events going on, lots of public engagement, and so why not have 2 or 3 days in Newcastle, watch some of the sport and find out about what's going on. Thank you very much.
If there's any questions from the audience, if you want to put your hands up and try and take some. But Paul, one to you, because you might have touched on it and I missed it a little bit. People excluded from transplant, it's not suitable for everybody. And you know the question about age, is that is that because of lack of donors, or the transplanted lungs are not successful after a certain age, which is a primary move?
All right. Well, it's a straightforward and simple question, but like many such questions, there are a number of riders to think about. So the first thing I would say is nobody is turned down on age criteria alone anymore. Having said that, it's rare for patients outside of their 6th decade to receive a transplant. And the reason for that is frailty is more increasingly common. It's the frailty of the individual. Plus, the drugs, the side effects of the drugs are particularly bad the older you get. So I always explain it like this. If I transplant a 25-year-old and at the 5-year follow-up I look at them, they look like a 30-year-old. If I transplant a 70-year-old and they survive 5 years, they look like an 85-year-old, and their quality of life is undoubtedly not quite so good. So it's not an ageist policy. It is what are you going to be like in 5 years? And if you're very frail, what are your chances of getting through the transplant? Because of the organ scenario, it would be wrong to use a donor organ in someone whose chances of getting through the operation and the post-operative period was really futile. So we don't want to embrace futility either. Does that meet the... Okay, questions. Don't be shy. You can ask anything. Yeah, there's one at the front here.
Do you have to...
Let's wait for the... Yeah.
Do you have to be so ill before you'd have a transplant, or can you be a well pH patient and be going for a transplant? So I know about the treatments.
Yeah.
And if you get to the end of the line with the treatments, but...
So that's a very good question. I mean, I think if you're well, so if you are, you know what I mean when I talked about low risk, you know, the traffic light system that many of the centres are using, green, amber, red. If you're firing in green and low risk, you certainly don't want to go for a transplant. Doesn't stop you talking about transplants, because it's best to think about them early, just have them in your mind. Because if you wait till you get absolutely desperate, then, you know, time can move very quickly, and it can be more of a problem for you. So you have to be sick enough to warrant a transplant. And generally we say, if your chances of living without a transplant are less than what you're likely to get with a transplant, that's the point where you should. Now, that's easy to say and more difficult to predict. But the experts in the transplant centres, there are pointers there. So, but as I said to you, my points, if you begin to think, I'd like to find out a bit more about transplants, even when you're well, there's no reason why you shouldn't.
Another question, Paul. It was about age again. Can you get to a lady of a certain age like myself? Age becomes, one of those questions you ask all the time. Is there an age limit to being a donor for transplantation?
Well, unfortunately there is, and I say unfortunately because there really isn't much good evidence, certainly from a lung viewpoint. I think certainly for hearts there is more of a problem, and like many areas in transplantation, one of the errors we've done over the years is to say, well, what works for organ A will work for organ B. So the heart, obviously the incidence of coronary disease or a bit of scarring in the heart, which means its function isn't so, and its ability to function after death is not so good in the older heart. But really for the lungs, although mid-60s is generally where the upper limit, you probably could go on, and there are certainly instances of organs from patients over the age of 70. Obviously, the risk of having of some lung diseases are more common the older you get, and the screening for lung diseases becomes quite tricky in donors. So I think if you were going to extend the age up, you'd need to be able to get maybe CT scans on everybody, because obviously the older you get, the more chances there are that you might have a lung disease that you didn't know you had. But if it's going to be transplanted into someone and then breathing for someone for the next 20 years, you don't want to be transplanting lungs with diseases in them. So there's a sensible kind of cutoff at the moment, but actually, if you could practically bring in a better screening method, you could push that age up. Because Methuselah's lungs were working pretty well, they tell me, when he died. I think he was about 300, wasn't he? Yeah.
Is your donor a similar age to you, or does that not matter?
Allocation goes on blood group and size. The age really doesn't. So the older you get, you don't get the older lung you may get. There's not an official policy, but I suppose there's a sensible, commonsensical approach that the third. So you would only, the primary allocation is definitively on how sick you are, irrespective of your disease, and whether you are the same blood group and whether you are similar size. And then we all have antibodies in our blood. These are proteins, and some people have developed antibodies, particularly if they've had blood transfusions in the past or other things. You can develop antibodies to some people's tissue typing. So in lung transplants, you don't actually have to do a tissue match, but it can be that some patients have developed, for whatever reason, antibodies against some tissue types. And if those antibodies are very strong, it makes you less likely to get a good outcome from your transplant. So there's as a sort of tertiary check on antibodies, but age doesn't come into it. No.
Okay.
Just going back to the repair centre for the lungs, was that essentially due to the fact you found that when the lungs were being raced over for transplantation, was there a higher percentage that you were finding they were damaged? And so that's where it came about initially to have that repair centre.
Well, that's a great question. The reason is that when you send a donor team out, you obviously get information on how the lungs are working in the donor on the intensive care unit, ventilated. When the team go out and have a look, and we've got a recipient in, the surgeon has prepared the chest. They're waiting, hovering, because you never open the chest until you know that organ is going to be used. What happens quite frequently is the surgeon who goes out looks and says, oh, I don't like the look of this, and things aren't quite as good as they used to be. And you have to make a decision there and then. What the organ repair centre allows you to do is to say, well, we'll take the lungs anyway, we'll bring them back, we'll have a look at how they're working, we'll try and tidy them up a bit, and you make that instant decision, something that can be done and shared and you can think about, because lung transplants tend to take place at 3 o'clock in the morning. I don't know about you, but I'm often not at my best at 3 o'clock in the morning. No comments from you, Ian. So the whole idea is to raise the percentage of organs we can actually use for transplant. Because when you hear NHSBT officials saying, yeah, we've got another 2 million people on the donor organ registry, it doesn't mean we're doing 2 million more transplants. And actually, we should be looking at the success of everything on the number of transplants done, not just the number of names on a theoretical list.
You know, my final question is slightly in line with that, Paul, and it's a lady who I know has been to Wythenshawe recently for a transplant assessment. One of the questions she was asked by the team there was, would she consider taking lungs from a smoker?
Yeah.
That debate I know is around at the moment. What's your comments about?
I would say there's clear evidence that you really can't afford not to take lungs from a smoker, because at the moment your chances of surviving to a transplant, if you won't have smoker's lungs, would be relatively small, significantly lower. And the adverse effects of smoking on lungs, providing there's no significant damage in the donor, is actually relatively small. So you actually gain successful, better life and a longer life if you are accepting of a smoker's lung than a non-smoker's lung. And the evidence for that is absolutely clear. So you are given that option, and I always advise my patients to say yes, accept it, even though there's obviously a smaller risk of, or a higher risk of that lung not being as perfect as you'd want it to. But hey, no lung is a new car. It's not like going to the showroom and knocking on your local Porsche dealer and say, I want the smartest Porsche. Lungs that we use for transplant aren't like that. It's that little car lot round the corner with the £2,000.
Lungs are us.
Yeah. So they're all second-hand lungs.
Yeah. It was the question that, and Sean, do you want to quote? Because I just want to, while we still got this sign up about this PowerPoint about the transplant games. It was one of the questions. I'm going to do a hands yes or no on this one. That question that we couldn't get up was that, regardless of the fact whether you got PH or not, if you needed transplanted lungs, yes, put your hands up to this one, would you be willing to take a smoker's lung? Yes.
They wouldn't now.
They wouldn't now. I just wondered if. So I think that's a really useful.
Yeah.
What about no?
Yeah. Fair enough.
Okay. Fair dues. Well,
we don't know is the answer, but maybe. There was a hand up. Yeah. Just wait for the microphone and then we'll get it.
If a patient's found to have antibodies,
yeah,
is there anything that can be done to reverse that, to make them more suitable to have possible transplant?
Oh, you've been doing some reading, I think.
No,
yes?
No,
well, that's a very good
it's
question.
just because I think I have.
The answer is yes. There are ways of removing the antibody, but they are quite involved, quite costly, and there's no doubting that you're better off for long-term results avoiding an organ which carries those little marker molecules on the tissues that your antibody recognizes, rather than suppressing the antibody. So the answer is yes, and in some cases we do undertake that. Largely and more often in heart transplantation, not so much data in lung transplantation, although it has been done, but we would only do that if we were really pushed into doing it, because generally there would be someone else waiting on the waiting list that would potentially make better use of that organ. Organ transplantation is one of those rare scenarios as a doctor where, when you've got a patient under you as a doctor, all your thoughts, actions, and everything else and responsibilities are devolved to looking after that individual in front of you. But in transplantation, we also have an altruistic gift from the donor family and the donor. And so there are responsibilities to make sure that you're trying to make best use of that organ as well. But the specific answer to your question is yes. And if the circumstances were such, there are ways of getting rid of those antibodies and having a successful transplant. But probably not as successful as if you didn't have those antibodies.
Sure, just so you sit down as well, Sean, the announcement of Transplant Games. Do you want the mic, or shall I have the mic?
No, you do it. You're
All right.
doing it. It's your baby, this one.
Thank you very much. So we've been, as Paul's mentioned, the World Transplant Games are held in Newcastle this year. And one of the things that the Games look for are forward-thinking charities to represent each organ?
Yeah.
So they approached us out of all of the lung charities, so you're talking the British Lung Foundation, the Cystic Fibrosis Trust, to partner up with them in Newcastle. So I'm very pleased to announce that we will be one of the sponsors at the World Transplant Games in Newcastle. So please, if you can, get yourselves down. We will be there. Thank you very much. Thank you very much. So what do we get from that? So as part, it's a very exciting opportunity to raise the profile of PH, obviously, the PHA as well, with the contacts that will come through that, the thousands of people that will go through their doors and compete. We also hope that it will generate awareness within our own community that this is an option, this is something that you can do post-transplant. So we get access to social media accounts, the vastness of PR that this will promote. They get Ian. Yeah. So out of that, we've done well. There is also a long... I tried. I tried. Couldn't get it in the contract. So the long-lasting, we were hoping to sort of develop a legacy from that as well, and that the follow-on effect of that is a 3-year sponsorship with the British Transplant Games. So the difference between the two is the World Transplant Games, very much like the Olympics, Paralympics, you have to qualify to take part and be part of that games. Whereas the British Transplant Games, very much like Eddie the Eagle back in the day, amateurs can just, you can show up, you can join in and just take part, meet new people, experience new things. And so I don't know what Ian's going to be doing at that, but we've got to get him doing something.
I'll do anything to get the message over. I mean, this is the point. This is the whole point of this. Is it's good fun. I mean, it's good publicity for transplantation per se, and it just one of the things I'm really proud of and proud on your behalf is that these people have approached us as the charity of choice to represent the lungs and that's a real credit to this organisation and to the work that we've done with people, clinicians. And with Paul, and particularly with Paul in this case, because of his involvement with the World Transplant Games in Newcastle. Where is it? Newcastle's up north, isn't it? Is it near Iceland?
Proper north.
Is it Iceland?
Proper north.
Right. Yeah. And one of the things that we get a chance to sponsor one of the games that's in the games, etc. So
right.
Yeah, and so now believe it or not, but this is the transplant game, so it's not necessarily, although there is some athletics in there. For the British Transplant Games, we've chosen, and we've got some reasons for this, which will become apparent, because we want you as members to be able to engage in this and probably take part in this, is that we've chosen darts
Oh, yeah.
Yeah, now darts is very, very popular. We believe there's a lot of publicity we can get from that. With the World Transplant Games, it is Patong.
Oh, that's the biggest. That's the biggest
Yeah.
participant sport at the moment.
Yeah, Patong. Now, if you don't know what Patong is, Google it. But it's like a bowls, isn't it?
Yeah,
It's,
French bull.
Bulls.
Yeah.
And it will be on the bulls. The Patong place will be on. It's on the River Tyne near the I can't remember which
It's
building.
by the Sage.
Yes.
So this, if you, where are we? The Sage is this side, isn't it? Are we looking upriver or downriver now?
You're
oh yeah,
looking
this is the
upriver,
pub
yeah.
here.
Yes, yeah.
So the Sage is actually here now, and it will be on prime location on the quayside between the Baltic. They've imported about 10,000 tons of gravel, and the Patong, there are about 20. I think they call them. I forget what they call it. It's not crown green, but they're like gravel pits.
Yeah,
But it's going to, and it's that there are more registrants. There's a lot of people who are running. Will also, I fancy doing the Patong. You're not limited to one sport. So actually, although most competitors are running in 3 or 4, they might do the 100 meters, 200 meters, just like you do in the Olympics. But everybody fancies having a go at Patong. So if you've got that, that's the blue ribbon.
Well, it's the one that we were hoping for, but
all right.
yeah. So it's exciting. It's opportunity. There are many ways. One of the things that is sure, even with these 3 here, we're not the sexiest disease going, PH, and we can try it, but we'll never be the boy band of
Wrong direction.
It's the wrong direction. This one. But there are many. I like that one, Sure. If you just made that up,
that was
that's
quick.
excellent.
That was quick.
Round of applause, quickly. Yeah, it's enough.
Very quick.